Hello everyone, welcome back again. My name is Dr. Sumit and I'm a maxillofacial and head and neck surgeon. The topic that we are going to cover today is mandibular angle fractures. So welcome to the oral surgical mind maps by Medi Study Go. What exactly are we going to cover in this particular topic right over here? The topic comprises of an index which consists of introduction and epidemiology, a mechanism of injury for angle fractures, all the clinical features for angle fractures, the diagnosis for angle fractures, various approaches for the angle fractures, and various treatment modalities. Alright, so let's start straight away with introduction and the mechanism of injury. So if you see this particular diagram over here, this area between the distal aspect of 7 and the distal aspect of 8, this area is considered as the angle of the mandible fracture. Anywhere above this, it's considered to be the ramus of the mandible. Anywhere anterior to this is considered to be the body of the mandible, and then of course the symphysis and the parasymphysis mandible fractures, as you can see on the screen. Alright, so why is this area most prone to fractures? Alright, this area is most prone to fractures because if you see the alignment of the mandible's internal osteological structure, which is also called as the grain of the mandible, runs vertically like this in the ramus areas, runs horizontally like this in the body areas. However, this angle area, it's a mixing and merging point of the vertical and the horizontal grain of the mandible. Furthermore, the presence of an impacted or a non-impacted third molar always affects the strength for this area. Alright, that is why the force required to fracture an angle of the mandible is much lesser than its other counterparts as the parts of the mandible. Another third factor which is responsible for making angle fractures one of the most commonly or most frequently fractured site is the pull of the masticatory muscles, that is temporalis pulling the coronoid superiorly, masseter and medial pterygoid pulling the mandible superiorly, and anterior belly of digastery and geniohyoid pulling it posteriorly. That is why a force is created in the angle area where the proximal segment tries to traverse posteriorly and the anterior segment, that is the distal segment, tries to traverse anteriorly. Alright, so now welcome to the overview of mandibular angle fractures by Medi Study Go. Alright, every detail that I'm going to mention in this part of the story is given over here. An overview of the mandibular angle fractures, fracture types, and fracture classifications. They are given right over here for your revisions. My job over here is to explain it to you what a vertically favorable and unfavorable and a horizontally favorable and unfavorable fracture looks like. So I want you guys to look at this particular diagram. So it has been an eternal confusion, right? That okay, when do we call it a horizontally favorable? When do we call it a vertically favorable? I'll give you a simple viewpoint. You look at the diagram. So over here, when you see this diagram, you're looking at the mandible from a horizontal perspective. And if the fracture line traverses postero superiorly to antero inferiorly, it means the pull of the muscle will get blocked by the fractured line, and that is why this is called a horizontally favorable fracture. And over here, if you see, the fracture line goes antero superiorly to postero inferiorly. The pull of the muscle will enable the movements of the mandible, and that is why it is called a fracture which looks unfavorable from the horizontal end, and that is why it's called a horizontally unfavorable fracture. Similarly, if you see this diagram from the vertical end, okay, this shows the mandible from a vertical end, and if you see the fracture line over here, the vertically favorable fracture line, it is traversing postero-lingually to antero-buccally. Alright, so what does that tell you? The pull of the medial pterygoid and the lateral pterygoid muscle, it is going to stop the movements of the mandible because of the direction of the fracture line, and that is why this is called a vertically favorable fracture line. And if you see this diagram over here, the fracture line which runs posterior and buccal and comes anterior and lingual, in this case the pull of the medial pterygoid, lateral pterygoid is going to enable more movements, and that is why this is called a vertically unfavorable fracture of the angle. I hope you guys have completely understood this particular concept. The next thing that I would like to tell you about is the clinical features. So if you see any fracture will bring in clinical features like pain, tenderness, step deformity, and mobility. What exactly is a step deformity? It's as simple as this. So when you have a discontinuous fracture line, if you palpate somebody's angle of the mandible or inferior border, and if there is a discontinuity which feels like a step, this is called a step deformity in the fracture line. So apart from pain, step deformity, what all clinical features do we have? It's an elongated facial appearance. Why? Because the angle fracture tends to move inferiorly. There is a massive swelling in the preauricular area, which also makes it look enlarged. Alright, flattened appearance of the lateral face because the angle fracture, if unfavorable, might even tend to move medially. Anesthesia or paresthesia of the lower lip. Why would that happen? If there is an injury to the inferior alveolar nerve, there is going to be a paresthesia. There is going to be a paresthesia for the lower lip and along the entire supply of the inferior alveolar nerve and the mental nerve. Apart from that, what are going to be the occlusal discrepancies over here? Ipsilateral open bite if the fracture decides to go downwards, ipsilateral gagging if the fracture decides to go upwards, alright, and a deranged occlusion. There could also be a posterior cross bite if the fracture line favors the movement of the dentate segment of the mandible medially, alright. So of course, these are your clinical features. What are the signs and symptoms that you are going to see as a doctor? Inability to close the jaw, which could be because of an ipsilateral or a contralateral open bite and gagging, swelling at the angle and the preauricular area, and painful movements. Because why? The fracture, it's trying to heal on its own. There is a hematoma, there is inflammation over there between the two fractured fragments, and that is exactly why there is going to be pain in that area. Pain is nothing but a defense mechanism of your body which tries to reduce movements over here. Alright, so coming to the main part, that is the approaches. Alright, please have a look at this particular approach over here. This approach that we have shown, this is called a residence approach or a submandibular approach. Alright, this approach is taken in the shadow of the mandible. This area over here just below the inferior border, this area is called the shadow of the mandible. Alright, this happens to be the shadow of the mandible, and this is where in the angle area, after palpating the masseter, you take an incision 1 centimeter inferior to the inferior border of the mandible. What are the various layers that you will see? Skin, subcutaneous fat, followed by superficial layer of deep cervical fascia. Once you go through the superficial layer of the deep cervical fascia, you are going to be able to see the masseter muscle, the marginal mandibular nerve, and the facial artery. You perform a basic Hayes-Martin maneuver where you ligate the facial vessels, retract the marginal mandibular nerve superiorly. You have an open exposure of the masseter. The moment you go through the masseter, this is the view that you are going to get. Alright, you're going to see inferior border of the mandible, probably even the superior border, and the entirety of the fracture line in the angle or the body area. Alright, so this over here is the submandibular or the residence approach, and the approach that you see over here, look at this. This is a standard wards incision taken from 7 till the distal aspect of 8 and then distally. This approach is called the intraoral wards incision approach over here. Alright, the plating that I have performed over here, this is one of my cases. The plating that I have performed over here, I've used a titanium plate 2.5 mm system. It's a thick plate because it was a displaced fracture. You can see the fracture line over here, and you can see the plating which I have performed across the external oblique ridge, as we have demonstrated in the Champy's lecture. All right. Now, the most important part, when you wish to write the modalities for the angle fracture, there is a particular article or a study. It's a landmark study that I would like you guys to quote. What is that study? That study is the Gair's modalities for treatment of angle fracture, where Dr. Gair has given some beautiful modalities, some various modalities for treating an angle fracture. What are these modalities? Please have a look. Modality number 1. Plating the angle along the external and the internal oblique ridge, which are the Champy's lines. Second modality, intraoral approach you take to plate the internal oblique and the external oblique ridge, and an extraoral approach has to be taken over here, which could be a periangular approach or a submandibular approach to plate the inferior border of the mandible. Modality number 2. So if you see modality number 3, look at this. There is a lag screw, which is a rigid fixation modality, which has been put through the external oblique ridge till the internal oblique ridge. That consists modality number 3. What is modality number 4? MMF, maxillomandibular fixation. We don't call it IMF, we call it MMF. MMF has been given over here between the maxillary and the mandibular teeth, along with one single Champy's plate along the external oblique ridge traversing to the internal oblique ridge. So again, this is Champy's plating plus a maxillomandibular fixation. All right. What is the fifth modality over here? The fifth modality over here is a strong recon plate or a rigid hardware plated via an extraoral approach, a submandibular or a periangular approach, and an intraoral approach taken to place a mini plate at the Champy's border or the external oblique ridge. Next modality by Gair et al. Again an extraoral approach where a strong 2.7 mm recon plate is used, a strong 2.7 mm recon plate is used to plate the external surface of the mandible, of the angle of the mandible right over here. All right. The next modality, which they have shown over here by Gair et al., this modality is two Champy's plates. Look at this. Champy's plate number 1 through intraoral approach on the lateral border of the ramus and the angle, and Champy's plate number 2 at the external, at the lower border of the mandible in the angle region through an extraoral approach. And finally, the biggest one, that is a complete transcervical incision where you open the neck, as you have seen in the previous lectures. You open the neck of the patient through a transverse cervical incision. It is reserved only for comminuted fracture, which needs an extensive reconstruction. So a strong Champy's 2.7 mm plate in adjunction with small mini plates along the Champy's line. It's a combined intraoral extraoral approach along with MMF, where you're placing arch bars. So this kind of a modality is strictly reserved for a comminuted fracture of the mandible. So these are all the modalities by Gair et al. Arch bars, that is MMF, Champy's technique, one plated external oblique ridge, Champy's technique with arch bars, two mini plates, again Champy's technique, tension band with bicortical plate, which is a strong plate, locking screw or a lag screw, tension band with locking screw plate, lag screw technique, 3D plates, which are nothing but strut plates. These strut plates look like this. They are rectangular, and if you place a strut plate on a mandible, it's like placing two parallel plates which are connected to each other. All right, and a 3D plate, and open approach with a universal plate. That is as far as the modalities of the angle are considered. And now let me come back to two very important pointers, that is the radiological assessment of the angle fractures and the basic complications in angle fractures. So we are here to discuss the radiological interpretation of mandibular angle fractures. What you see over here in this particular OPG is an angle fracture. All right. So now have a look at this. This is the left side of the OPG, where there is an obvious discontinuity. Look at this. This is the internal oblique ridge. This is the inferior border of the mandible. This is the alveolar crest. And this is the inferior border of the mandible. There is this obvious discrepancy that you can see at the inferior border and the superior border. This discrepancy is marked by an almost straight line. All right, this straight line which appears as a mixed radiolucent radio-opaque line over here, which clearly shows you that there is a discrepancy over here in the superior and the inferior border. Also, as an interpretation, if you can see, this is the superior cortex of the canal, this is the inferior cortex of the canal, which carries the inferior alveolar nerve. Over here, this is the proximal segment, this is the distal segment, and look at this. Again, this is the superior cortication, this is the inferior cortication. So most likely the clinical features that this patient is going to have in this particular case, it could be paresthesia. Why? Because there is a very obvious breakage in the cortication of the nerve. Apart from that, this fracture could be infected. Can you take a guess why? This fracture is most likely infected because the periodontal ligament of this particular third molar has been infringed by the angle fracture. So whenever there is an infringement or a damage to the periodontal ligament of the tooth, that tooth can be considered as indicated for extraction. This is the kind of tooth that you want to extract. Why? Because it could cause a potential infection when you reduce this fracture and when you try to plate it. Alright, look at this. The second OPG that I would like you guys to see is this one. So this is of course a plated bilateral angle fracture. What I want you guys to see is there are multiple radio opacities that you see over here. 1, 2, 3, 4. These opacities are nothing but MMF screws which were used to retain the occlusion. You see a fracture line over here, which is Y-shaped in nature, a second fracture line over here. Alright, so these fracture lines, they represent as radiolucent linear radiolucencies. Alright, in the angle region. Look at this, they have extracted, you can see the sockets of the third molar over here and over here. They have extracted both the third molars, and these radio opaque hardwares that you see, these are nothing but the mini plates that are used. How do you describe them? A mini plate is seen which is most likely a 6-hole with gap mini plate. Look at this, 3 holes here, 3 holes here and a gap in between, 3 holes here, 3 holes here and a gap in between. So these mini plates are nothing but 6-hole with gap mini plates which are used to plate a bilateral mandibular angle fracture in an orthopantomogram. The third one that you see over here, a little bit of a low grade OPG, but I have included this because I wanted to show you something. Look at these. These platings are done according to the Champy's lines. One plate at the inferior border, one plate at the subapical area for a body fracture that runs oblique. And the second fracture line, you guys can see it over here. It's a linear radiolucency running from the clinical angle to the surgical angle of the mandible, and a 5-hole continuous plate is used over here. 2 holes and 2 screws on either side and a hole for a gap in between. That is a plated mandibular angle fracture with a plated body fracture, as you can see in this OPG. And this is nothing but a 3D reconstructed CT that you can see over here, where a fracture line is seen running from the superior aspect to the inferior border of the mandible, and it is infringing the periodontal ligament of a mesioangularly impacted third molar. Alright, that is exactly how in an examination you interpret an OPG if handed over by your examiner. And for the final part of the lecture, what are the complications for ORIF, that is open reduction internal fixation of mandible fractures? Alright, non-union or a malunion. So if because you have not plated properly, let's say there is micromobility or mobility in your plate because of which the fracture fragments are not fused to each other, in that case it will lead to a non-union. Or if you have done a good plating but the borders are not merging with each other, that leads to a malunion of the fracture. There could be infection, there could be abscess. Why? Because like I said, if you have a periodontal infringement, if you have an intraoral communication, saliva is continuously trickling into that part of the cavity where you have placed a titanium plate in a very, very, sterile manner, and that could get infected, that could cause an abscess. Hardware failure. Why do you have a hardware failure? A hardware failure basically means either your plate is broken, or your plate got so infected, or there was so much infection that there was bone loss and you had to remove that plate. This kind of a situation is called a hardware failure, which is seen in immunocompromised patients or the patients which get unfortunately infected. Nerve injury, like I showed you in the OPG, if there is a massive discrepancy in the proximal and distal segment where the cortication of the canal has been completely hampered and broken, in that case, a nerve injury to the inferior alveolar nerve or the mental nerve can be very, very evident, and it can present with paresthesia or diasthesia. All right, dental injury, of course, there could be avulsion of the teeth, there could be fracture of a third molar, there could be a sectioning of a third molar, which is not done intentionally. Of course, it's a fracture, so that could cause a dental injury and TMJ dysfunction. See, TMJ is a whole different topic altogether, but why am I taking the pains to explain that? Because if you are not properly fixing a mandibular angle fracture, if there is a malocclusion, if there is an open bite on one side, if there is a gagging on the other side, in these kind of scenarios, the TMJ, the joint or the head of the condyle, does not sit properly in the glenoid fossa, and that leads to the internal derangement of the temporomandibular joint, which could also be caused because of a badly operated trauma. Alright, so the lecture is over, but are we done yet? No. Like I always say, every topic needs some kind of revision, and for that revision, we are here with our flashcards and MCQs. Question number 1. What are the different modalities for treating a mandibular angle fractures? If you're asked about this one particular question in your exam, I want you guys to come up with the Gare's treatment modality criteria, which I explained over here, which explains over 10 different techniques for plating a mandibular angle fracture. Single mini plate, double mini plate, Champy's lines of osteosynthesis, a recon plate at the inferior border, a combination of a recon plate with a mini plate. Go as much as you can. At least 7 to 8 modalities can be easily quoted and easily be told about in this answer. Second one, the Champy's lines of osteosynthesis need not be followed for which part of the mandible? Option A, symphysis, B, body, C, angle, and D, subcondylar fractures. So let me tell you, for subcondylar fractures, you have a different kind of criteria, which is called a Lakota's line. Alright, and the Champy's lines of osteosynthesis does not extend beyond the external oblique ridge into the anterior ascending ramus, and that is why the correct answer for this is going to be subcondylar fractures. My third question for today is going to be, what is a stress shielding phenomena? So as I had previously explained in the lecture, when there is a recon plate reconstruction, it takes away the forces of muscles of mastication and occlusion, and because of the functional matrix theory, the bone at the fractured side gets a message, and that is where the bone gets resorbed, and this phenomena is called a stress shielding phenomena. Alright, that is what I want you guys to answer in the Viva. The notes are clearly given right here on the screen, as you can see. And my last question for today, that is going to be, which of the following muscles do not have a direct effect on the mobility of an angle fracture? Masseter, temporalis, anterior belly of digastric, and genioglossus. So technically speaking, masseter, temporalis, and anterior belly of digastric, these are all muscles of mastication. The first two are primary, the second one is a secondary muscle of mastication, but the genioglossus is a fan-shaped muscle which resides inside the tongue. It does not have a marked effect of mobility on any of the mandibular angle fractures. And on that note, I thank you very much for attending our lectures. This is us from the Medi Study Go team. I'm Dr. Sumit from the oral surgery team, and I'm looking forward for you guys to attend more of our lectures. Thank you very much.